ratio is 1.2. Direct anticoagulant test. Coombs test is negative. Peripheral blood smear reveals rare schistocytes. Renal ultrasonography reveals normal-sized kidneys with no obstructive or renal vein thrombosis. Renal biopsy shows capillary congestion and intracapillary fibrin thrombi consistent with thrombotic microangiopathy. Immunofluorescence testing reveals deposition of fibrin but not IgG, IgM, or C3. Which of the following is the most appropriate next step in this patient's treatment? 1 heparin, 2 prednisone, 3 prednisone plus cyclophosphamide, 4 plasmapheresis plus fresh frozen plasma, or rituximab.
What do you think?
Rituximab.
Rituximab is used in lupus, severe lupus, but it's not first line. Which one? Prednisone, probably she's already on prednisone, but the schistocytes is actually hemolysis. So every time you see schistocytes, that's very abnormal. Schistocytes, you think immediately about TTP, some sort of hemolytic anemia. In the right context, it's always hemolytic anemia. But when you see schistocytes plus renal failure plus something else, that's either TTP or some sort of like severe autoimmune disorder. Like this person actually needs to be anticoagulated right away because this person has like a risk of catastrophic antiphospholipid antibody syndrome. So one of the advice I give to students is make sure you read what they're asking you, because it's not necessarily what is the diagnosis. It's just like what is the most appropriate next step in the management. Right now, you have a patient with like presenting with like very abnormal lab findings and systemic involvement. So if you don't do something, she's going to end up having catastrophic antiphospholipid, and this is a clear-cut indication to anticoagulate the patient. So you admit the patient, you put them on a heparin drip, and then you transition to Coumadin, and they probably need to be on Coumadin for the rest of their lives. So again, you do the diagnosis is you screen for any of the antibodies. There's several, and they may give you a history of like miscarriages or thrombocytopenia. And you have to determine that if the neurological or the renal manifestations are either from lupus or they're from the antiphospholipid antibody, because the treatment is very different. For one, you need to anticoagulate versus the other one, you need to give like a lot of steroids. So that's why prednisone is not the right answer. So this person actually probably does have like severe APLA syndrome. All right, somebody wants to help?
Knees and ankles accompanied by occasional swelling of the wrist and hands. Over the past 3 months, the joint symptoms have worsened. She has had intermittent mouth ulcers, redness of the cheek, and pain on inspiration. She was started on naproxen 1 week ago, and she states today that her joint and chest pain have decreased by approximately 80%. Takes no other medication. On physical exam, temperature 37.1, blood pressure 134/82, pulse 84, respiration rate is 16. Cardiovascular exam is normal. There is mild malar erythema, and there is 1 ulcer in the palate. Cervical and axillary lymphadenopathy is present. Abdominal exam is unremarkable. Examination of her hands reveal ulnar deviation and metacarpal subluxation. Deformities in her hand are reducible. She has full range of motion of all joints. Wrists and ankles are mildly tender. Hemoglobin 12.9, leukocyte 3900, ESR 42, RF 50, C3 40, C4 10, ANA titer is 1 to 640, anti-Rho and SSA is positive, which is the following treatment for the patient.
What does the patient have? One says lupus, the other one Sjogren. It's more like elderly. This is like polyarthritis. involving the hands. She's having like redness of the cheeks, pain, and inspiration. Say it again. Hydroxychloroquine. Very good. And the reason why hydroxychloroquine is very effective in controlling articular manifestations of lupus is actually the drug of choice. So you do that plus or minus NSAIDs when you can give NSAIDs. And when they flare in, you give a little bit of a steroids and you try to taper as soon as possible. So the other steroid sparing options are cyclophosphamide, but cyclophosphamide is either oral or IV pulse dose for a total of 6 months. But you don't want to use cyclophosphamide unless you have to in the young female in reproductive age, because it can cause, what happens with cyclophosphamide? Infertility. That's actually one of the side effects. It can also cause interstitial, right? It can cause like cystitis and increase your risk of hemorrhagic cystitis and risk of bladder cancer. We use a medication called Mesna that binds like one of the sulfide groups, and it lowers your risk of developing bladder cancer. So we do it like before and after the infusion, and there's so much cyclophosphamide that you can give. Like typically, just to give you an idea, in my field, I prescribe somewhere around 0.5 grams per body surface area, versus in oncology, the typical, like let's say the R-CHOP protocol for lymphoma, they prescribe like 2 grams per body surface area. So my patients, they rarely develop like all the side effects, versus the cancer patients that when you give them this much Cytoxan, they all have like hair loss, they become profoundly cytopenic, like leukopenia, especially like after 2 weeks, because that's when the nadir of peak of action of this drug reaches the maximum effect. And but in my field, like they rarely have these side effects. But again, cyclophosphamide is reserved for renal manifestations or for those patients having severe systemic manifestations like CNS or renal manifestations. Remember, lupus back in the 70s and 80s was a very lethal disease. Actually, like a lot of it had a high mortality. Nowadays, with cyclophosphamide and with mycophenolate, if the patients are compliant and they actually have access to good health care, because that's another thing that research shows, is that there's a big disparity in the outcomes depending on your socioeconomical status. If you're poor and you have no access or transportation or follow-up or adherence to the treatment, these patients, they do very poorly. But for those that are able to have all the things that I mentioned, they do pretty well. And the life expectancy is just the same as a normal individual, because the disease is not curable, but we can put it in remission. And the likelihood of putting this disease in remission is pretty high with either cyclophosphamide or mycophenolate. Azathioprine is more like is not an induction, it's more like maintenance for those patients that actually got Cytoxan or induction doses of mycophenolate. You can keep them, you can do the maintenance with Imuran. You guys know what the most common side effect of Imuran is? It's an anti-metabolite agent. So if you're on Imuran for a long time, you can actually develop like serious skin cancer, like squamous cell skin cancer. So that's the reason why a lot of these patients that we give them immunosuppression, or transplant patients for your boards. Transplant patients, the most common cancer in transplant patient is squamous cell carcinoma, because of the anti-metabolites, either Cellcept or Imuran. No problem.
Would their risk be reduced with like extensive sun protection, or is it just
Absolutely, and that's part of the recommendations. You're gonna, this may sound silly, but a board question is gonna, on preventative medicine, is gonna say important recommendation is that you educate every patient avoiding sun exposure, in particular those patients taking these medications. And you need to tell them to use protective sleeves, long sleeves, and sunblock every day, especially in beautiful Southern California. Okay, so these patients, again, the Plaquenil is part of their management for those suffering from mild involvement or articular manifestations. Okay, next question, please.
A 45-year-old woman is evaluated for a 2-week history of recurrent chest pain. She has a 6-month history of arthralgia, 2-month history of myalgia, and mild proximal muscle weakness. She has difficulty climbing stairs, rising from a chair, and removing dishes from a high cabinet. She also has a 10-year history of Renal phenomena. A physical exam, temperature is 36.4 degrees Celsius or 97.6 Fahrenheit. Blood pressure is 125/78, pulse is 90, respiration is 18. Cardiopulmonary examination is normal. Abdominal examination is unremarkable. There are peeled ulcerations on the second and third fingers of the right hand. There's no synovitis. Proximal upper and lower extremity muscle strength is 4 out of 5 and is associated with mild muscle tenderness. Lab hemoglobin is 12, ESR 63, creatinine 29, CK 96, AST 8, AL 267, alkaline phosphatase B, ANA titer of 1.560, UA is normal. Chest X-ray shows blood to the cardiac angles. Which of the following antibody assays will confirm the most likely diagnosis?
What do you think? Sarcoidosis can happen at any age. But which one is the test that you sent for sarcoidosis? Which one is the test when you suspect sarcoidosis? And what else?
The
ACE level. Yeah. So what do you think she has? She has Raynaud's, right? She has a positive ANA. She has like decreased proximal muscle weakness. What's that? Scleroderma? Yeah, so ribonucleoprotein. So this is a very, very complex territory in rheumatology. So you either have mixed connective tissue disease. These patients, they share features of lupus, and they have like myositis, or they may evolve to look into like a scleroderma. Like they may give you like the classic scleroderma skin findings. But these patients usually they respond to steroids. Whereas the patients with Sjogren, and they have like the anti-SSA and SSB may be positive. But these patients actually they have like, remember that I told you earlier that rheumatoid arthritis, they can develop lymphoma. So if you have rheumatoid arthritis and Sjogren syndrome, your risk of having lymphoma is like 40 times higher. So it's not good to have the constellation of symptoms. So when they give you, on your boards, if they give you a patient that looks like lupus, but they're emphasizing on skin or proximal muscle weakness, think about mixed connective tissue disease. And the antibody associated with it is the anti-RMP. Okay? Okay, any volunteer?
A 60-year-old woman is evaluated for a form of history of progressive fatigue and dyspnea on exertion. She does not smoke cigarettes and denies chest pain, palpitations, dizziness, or syncope. She has a 12-year history of limited cutaneous systemic sclerosis. A screening cardiopulmonary evaluation 3 years ago is normal. She also has gastroesophageal reflux disease and the Renal phenomenon and intermittently develops ulcers on her fingertips. Current medications are amlodipine, omeprazole, and nitroglycerin ointment. On physical exam, her temperature is 37 degrees Celsius. Her blood pressure is 120/80. Her pulse is 84. Respiration is 16. Cardiac exam reveals a loud pulmonic component of S2 with fixed splitting and a 2 out of 6 early systolic murmur at the left lower sternal border that increases with inspiration.
Like a pulmonary hypertension description, like fixes too.
The lungs are clear to auscultation. The abdominal exam is unremarkable. Sclerodactyly is present and kidney scars are visible over several fingertips. There's no peripheral edema. Complete blood count and erythrocyte segmentation rate are normal. Electrocardiogram shows evidence of right ventricular hypertrophy. Chest radiograph shows no infiltrate. Her lung pulmonary function tests.
Mm-hmm.
84% predicted for the FVC and the forced expiratory volume first second. Like that ratio is 0.8. And then, I don't know, DLCO.
Diffused lung of carbon dioxide. We do that like to assess like this what's involving the how do you call the space, the membrane, blanking out, the alveolar arterial barrier. How you call that space? Jesus.
It should be low in asthma
Yeah, it should be low in asthma and any disease that actually interferes with the membrane can actually be low. So what are the symptoms? You know, this lady has a lot of constellation of symptoms here, right? So what do you think is the more likely diagnosis?
Hitting stars make me think of some kind of
Sarcoidosis.
Sclerodactyly with,
Jacob, these are scleroderma.
Right. And what kind of disease involvement?
Interstitial lung
Right. This pulmonary arterial hypertension. Remember I told you is a fixed S2 with the splitting? So why am I bringing it up? Because there is a systemic involvement. With systemic sclerosis, we have like diffuse organ involvement, and these are things that you need to concentrate. You need to know that the scleroderma, renal crisis, they may give you a question with this, like the patient is severely hypertensive and acute kidney injury, you need to treat them with ACE inhibitors. Even if they're pregnant, you need to give it to them because that's the only way you can actually save them from going into irreversible renal failure. And you also need to know the disease association of the watermelon stomach. Have you guys heard about the watermelon stomach? Have you ever seen the slide of that? It's like a lot of, how do you call? A lot of the stomach, the antrum of the stomach, it has like these big folds. It almost looks like a watermelon. Let me see if I can pull a picture. Search the web for watermelon stomach pictures.
Here are some images of watermelon stomach I found on the web.
You've never heard of that one?
No.
So you need to know that one. Looks like a watermelon.
just like so descendant of
the streets that they do that endoscopy.
They do endoscopy.
Oh, wow.
So when they give you the gastric, when they give you a case with these symptoms and they give you a watermelon stomach, like you're dealing with scleroderma, it's a gastric antral vascular ectasia. And you need to know the other disease associations like interstitial lung disease and pulmonary hypertension. The CREST syndrome, have you guys heard about the CREST syndrome? So calcinosis, Raynaud's, lower esophageal dysfunction, sclerodactylia, and telangiectasias. And the antibodies that you actually, when it's limited scleroderma, you do the anti-centromere. When it's diffuse scleroderma, you do the anti-topoisomerase antibody. I don't think you're gonna get that on your boards. This is probably more like for internal medicine boards, but I put it there for your review. I don't know how sophisticated they are on the boards these days. I remember they were getting harder and harder. I have to retake mine in 2 years, so it's not gonna be fun for me. Yeah. All right. Next question.
Answers.
Oh, shoot. So, okay. Wegeners, we don't call it Wegeners anymore, right?
No, granulomas
With polyangiitis, GPA. Right. So basically, teaching points for you guys, if you get an adult with recurrent otitis, adults don't get otitis. You have to look for either a risk factor, either there is a smoking history, or there is some anatomical problem, like a structural anatomical problem, or the patient has a small vessel vasculitis and they kept getting treated. One of my dialysis patients, actually, the diagnosis got delayed by about 8 weeks, because the ENT doctor was treating him over and over for otitis, and the guy actually had small vessel vasculitis, GPA. So if you see recurrent sinusitis, recurrent otitis, you think about small vessel vasculitis, ANCA. So Wegener's until proven otherwise. Okay, so why don't you, I'll take a volunteer to read this one.
82-year-old woman is evaluated for flare of polymyalgia rheumatica manifested by aching in the shoulders and hips that began 2 weeks ago. She has fatigue and malaise. She was diagnosed with polymyalgia rheumatica 8 months ago. At that time, she was prescribed prednisone 20 milligrams per day. Her symptoms promptly resolved, and her prednisone dose was gradually tapered. 4 months ago, her prednisone dose was decreased from 7.5 to 5, and her symptoms returned. The prednisone dosage was then increased to 10 and followed by a slow taper of this agent. Her prednisone dosage was most recently decreased from 7 to 6, which is her current dosage. She also takes calcium, vitamin D supplements, and a biphosphate. On physical exam, vital signs are normal, range of motion from shoulders, neck, and hips elicit mild pain. There's no temporal artery tenderness. Which of the following is the most appropriate treatment for this patient?
So we all know that this person has PMR, and you try to go down, because that's one of the very important treatment goals, is that you try to go down to the lowest possible steroid dose, even if it's something like 7.5 milligrams is better than 8. 8 is better than 9. So this is common in clinical practice, that we try to go down as tolerated. And the patients, they do know, and you teach them, like when you have a heart failure patient, you teach them like Lasix. Okay, you're having more symptoms or you're gaining weight, you're gonna self-adjust your Lasix. Same thing we do in rheumatology. We give them 1 milligram pills, and we tell them like you're gonna start going down as tolerated. So this person seems to be flaring from a PMR. It's very safe to assume that she has a PMR. And now you need to basically start treating them again. So what would be the next best step in the management? Would you go to 7.5 and add methotrexate, or you add what's the name of infliximab? You mentioned it. It's called, no, it's Remicade. Yeah, infliximab. So actually, you go back on prednisone. You increase a little bit, and if they're failing it, you do methotrexate. The teaching point from this question is that the first line is always prednisone. If they're failing prednisone, there's so much time that you can keep someone on prednisone. Before, we used to keep patients in very high dose prednisone. Just as a historical fact, kidney transplants have been there like for about 40 years. They started transplanting kidneys. All of those patients, they were dead by year 2, 3, 5, because they were giving them enormous amounts of prednisone. We didn't have calcineurin inhibitors. We didn't have like the rapamune, the mammalian target of rapamycin inhibitors. We didn't have like the new medications that we have now for organ rejection prophylaxis. So patients were treated with 40, 50, 60 milligrams, and everybody was dead. So in these rheumatologic diseases, your goal is to always bring it down. And if you have to keep the patients on prednisone long term, you have to be conscientious of it, and you need to make sure that you give them gastric prophylaxis, because they can get stress ulcers. You need to give them osteoporosis prophylaxis with Fosamax. No matter how old you are, if you're going to be on steroids over 1 year, for sure you need to give them some sort of like Fosamax, and you need to try to make an effort to try to bring them down. So when this person is already failing, you need to start thinking about maybe they're going to need a little bit of extra help, and methotrexate actually helps for that. Okay. Next question, if somebody can help.
A 20-year-old woman is evaluated for a past history of malaise, fatigue, myalgia, occasional headaches, and unintentional focus bacteria loss. 5 weeks ago, she began to develop pain in her arms and legs when exercising in the gym. This pain resolves with rest. On physical exam, temperature is 37.3, blood pressure is 180/95 in the right arm and 110/70 in the left arm. Pulse rate is 84, respiration is 16. Ability is heard over the left circulating artery and left leg. The radial pulse is absent on the left side, and dorsalis venous pulses are absent bilaterally. Labs, hemoglobin, 9.2, leukocyte count is 14,000 ESR is something that is seen currently is 1.1, usually is normal, checkups is normal. Which of the following most likely cause increased one is ventricular, two is PO, three is polyangiitis nodosa, and four is artery stenosis.
What do you think?
I think it's four. No artery stenosis.
Because of the hypertension?
It's the young woman with the
And how do you explain the bruit, like the discrepancy and the blood pressure? One arm and the other.
it's coarctation.
No, coarctation, remember, coarctation gives you like discrepancy in the upper and the lower extremities. No, when you have the difference is because there is some sort of like narrowing or stenosis in one of the peripheral arteries, like one of the subclavian. So what I'm trying to ask you here is about a person with like significant stenosis in one of the arteries that gives you a discrepancy. I don't know if you guys still do it, but Dr. Ben-Zur used to check blood pressure in both arms to his patients. He still does it? Only new patients? Okay, he still does it. So you're looking for like this kind of discrepancies. And I was telling, before you guys came in on board, I was talking to the students yesterday about renal artery stenosis in a young female. You always think about fibromuscular dysplasia. In an older person, you think about atherosclerotic renal artery stenosis. They're completely different entities and they're managed very differently, because the way we manage patients with renal artery stenosis from fibromuscular dysplasia, we give them angioplasty, sometimes a stent. Whereas the patients with atherosclerotic renal artery stenosis, we know that we no longer do that. Only in very selected cases we do the stents, because the outcomes are pretty much the same. If you give them Plavix, aspirin, statin, and an ACE inhibitor, the outcomes are going to be similar. We only do it for those patients suffering from very high blood pressure and they still have normal renal function. Those patients, we do refer them to get a stent in the setting of atherosclerotic renal artery stenosis. But in a 20-year-old woman, like the one I'm describing here, she has basically like chances of having atherosclerotic renal artery stenosis is very low. So this person has a vasculitis probably, and this is something that needs to be addressed as a systemic disease. So this person probably has involvement of the renal artery and also involvement of the subclavian vessels. That's why you have this discrepancy in both arms. And there's some vasculitis that are associated with bigger vessels. You guys remember? Like which ones? Small vessels, medium, and large vessels? You guys remember?
Giant cells and large vessels.
Okay.
Arthritis and
Takayasu, very good. Very good.
And Kawasaki is the medium.
And then you see that in which population?
Young Asian kids.
Pediatric, right? And then it's very important that you guys never miss that, because they can, right? Strawberry tongue, and like you have to have a high index of suspicion. You never, as a pediatrician, that's a nightmare. I have a friend who's a pediatrician, and he tells me that he gets very stressed out sometimes sending patients out, because sometimes you don't know. Clinically, you have to wait for labs, and you gain, I think, with experience. That's one thing that we all go through when we're early in this business. We are very inefficient because we're panicking about all these things. Like I was just telling you guys, like these are rare diseases, but when you miss them, it can be catastrophic. So in pediatrics, that's the nightmare of a pediatrician. Okay, what about medium vessel vasculitis? Polyarthritis nodosum, yeah? No, that's a small vessel. That's a small vessel vasculitis. And the small vessel, Church-Strauss, we don't call it that. We call it eosinophilic. They call it.
That one's a small vessel, right?
It's a small vessel, yeah. All of the ANCA, like all the ANCA are small vessel vasculitis. And then we have like cryoglobulinemia, which is also a small vessel vasculitis. And cryo is associated with what disease? Cryoglobulinemia. Cryo? Hepatitis C. Hepatitis C. So Hep B is PA, polyarthritis nodosum, and Hep C is associated with cryoglobulinemia. Yeah. So these are basically The medium vessel is the Kawasaki and the PAN. Kawasaki because the coronary arteries. And the small vessels, we have the ANCA positive. So either MPA, Wegener's, Church-Strauss, or drug-induced. ANCA negative is either Henel-Scholl purpura, lupus, or some drug-induced, or the leukocytoplastic, but these patients, they have a lot of like skin manifestations. And on the large vessels, we have the ones that you just mentioned. The giant cell in the boards, they want you to always recognize the association with like the retinal artery involvement and possible blindness. That's why you have to properly start treating them with steroids and do a temporal artery biopsy. You don't wait for the results, you start giving them steroids and then you biopsy. And polymyalgia rheumatica and the Takayasus. So inflammation of the blood vessels that causes like vessel narrowing, blockage, aneurysm or rupture, and it can be either primary or secondary, but you always want to remember that vasculitis, we always talk about small vessel, medium, and large vessels. Okay? I don't deal with this, fortunately. I think it would be very stressful. And I want you guys to always remember, if you end up working in urgent care, think about it. If the kids are not getting better, they're having a fever for a long time, you cannot miss that. You give aspirin, yeah. IVIG, yeah. And you know, and sometimes you need to admit these kids because they can have ischemia, coronary ischemia anytime. Okay, so this slide is a very busy slide, but just to show you that we used to call it the GPA, we used to call it Wegener's, but we also have the microscopic polyangiitis, which is the other spectrum. So remember, ANCA can be positive for C-ANCA or P-ANCA. ANCA is reported in two different times. If you have positive ANCA, you need to wait to understand either it's a cytoplasmic ANCA or it's a peripheral ANCA. So it's an immunohistochemistry, and that's why it takes like 3 more days for the test to come back. And it's a technician dependent, so they report it based on the anti-nuclear antibody pattern. So we know that most patients with Wegener's, they have C-ANCA, whereas most patients with MPA, they have like a P-ANCA, so perinuclear pattern. These patients, they present with, they can both present with pulmonary renal syndromes, so that's one of the manifestations, but Wegener's usually is more like upper respiratory, lungs and kidneys, whereas the MPA is mostly like lung and kidneys confined. And we have the what we used to call Church-Strauss, we call it eosinophilic granulomatosis with polyangiitis. These patients can have like the pulmonary infiltrates. They can present with mononeuritis multiplex. Remember I told you guys, if you have a patient with an acute peripheral nerve involvement, you think about that. And one of the hints to think about this disease is patients can either have peripheral eosinophilia, or they can see on the biopsy, whatever tissue you biopsy, either you biopsy the lungs or the kidneys, you see a lot of eosinophilic infiltration. And these patients, they have to have the same type of treatment with Cytoxan and prednisone. We treat the 3 conditions. It's more like a distinction about prognosis, but like pulmonary renal syndrome is more commonly seen in C-ANCA, but the treatment actually is the same for the 3 conditions. And then we have another type of a small vessel vasculitis, the Cryoglobulinemia Vasculitis. This is actually, we call it cryo because the immunoglobulins that form, they precipitate in cold, and that's why you actually, when you collect the sample, you need to put it in ice right away. I did that as a resident, I did that as a fellow. You do the blood draw, you put it in ice immediately and you take it to the lab. If you don't put it in ice, you're not going to be able to detect the cryoglobulins. And the disease association that I want you guys to remember is that Hep C can be associated with this condition, but it's not always Hep C related, by the way. So these patients have palpable purpura. Have you ever seen palpable purpura in a picture, in a medical school, a medical textbook? No? Mm-hmm. Search the web for palpable purpura pictures.
Here are some images of palpable purpura I found on the
web. If you see these, don't miss it. You can feel it. This is very abnormal. This is a small vessel vasculitis, very likely to be cryo. Yeah, so you can feel it, like very abnormal rash. You know, you see this, like you better believe that this is the real deal. So these patients actually, they can have like severe systemic symptoms, mononeuritis multiplex. They can have like glomerulonephritis, and there is a type, like a subtype that can be associated with Hep B. I don't think the boards are gonna ask you that question. They're very straightforward. Hep C, cryo, Hep B, PAN, polyarteritis nodosum. And then we have the HSP, which is usually IgA deposition, and it's totally, in the renal biopsy, is indistinguishable from IgA nephropathy. And that's why some researchers, they say like this is a spectrum of IgA nephropathy. You guys know that IgA nephropathy is the most common GN in the world, right? It's usually like in Latinos or Southeast Asians. And a lot of the times, most patients, they actually have a very indolent course. They don't have anything. They get picked up because whatever, they were trying to buy life insurance, or they got a physical and they detected microscopic hematuria. Those patients we don't biopsy because, again, the course is very indolent. We only biopsy patients when they actually have proteinuria or the renal function is changing. We do a renal biopsy just to try to understand what the diagnosis and prognosis is. But the interesting thing about IgA nephropathy is that most patients they go unrecognized. Some patients have very slowly progressive course until they become dialysis dependent. And some patients, actually, they have a very, very aggressive type of presentation, and they develop what we call in nephrology an RPGN. So I don't know if you heard about an RPGN, but that stands for a rapidly progressive glomerulonephritis. That's the nightmare of a nephrologist. Like I always think about, like, what is the nightmare of a cardiologist? Probably missing a LAD lesion. Like, let's say somebody was having anginal symptoms and they had an LAD lesion. Let's say you do a stress test and you fail to recognize like depressions on the stress test on the anterior leads. So that's probably the worst scenario for a cardiologist. For a nephrologist is that we see a patient and we send the patient out and we bring back the patient in 6 months, and in 6 months he never makes it to 6 months and the patient gets admitted with renal failure and they need to start dialysis. And I'm saying this because time is very time sensitive. If I unrecognize this in 3 months, an RPGN can go from normal renal function to dialysis dependence, because there's a lot of inflammation, activity, infiltration. Have you guys heard about crescents? So crescents are it's very active, nasty inflammation of the kidneys. And if you don't detect that and you don't start treating, guarantee these patients are going to be dialysis dependent. Yesterday in my clinic, I saw she's now 20. When I started caring for her, she was 18, Filipino. Came in with microscopic hematuria and lower extremity edema. And that was very clear. When I got the consult, it was very clear that I needed to biopsy that patient. So the next day that I biopsied the patient, I got a call from the renal pathologist, and he told me, like, you know, this lady has, I haven't done the EM. You guys know that the renal biopsy, we do a light microscopy, an immunofluorescence, and an electron microscopy. So there is always like the light microscopy, I get a read within 24 hours, whereas the immunofluorescence maybe 2 or 3 days, but the EM is always like 1 or 2 weeks. And the guy told me, like, you know, I'm gonna tell you that this lady, I haven't done the immunofluorescence or the EM, but she has probably IgA nephropathy because all the involvement that I see. And this lady, you better call her because this lady has like 80% crescents. Her kidneys were completely replaced by crescents. Inflammation, very active. So I had to call the lady, admit her to the hospital, give her very high pulse dose methylprednisolone, sodium medrol, and treat her with Cytoxan, which I felt pretty bad because I'm talking about an 18-year-old female who I already told you that you can actually cause infertility by giving Cytoxan, but it's either that or dialysis dependence. And I explained that to the patient and the mom, and we have some strategies to protect the ovaries. We give progesterone. There's something called Mesna. No, not Mesna. Lupron. Lupron is a high-dose progesterone supposedly there's some studies suggesting that you protect the ovaries by inducing amenorrhea and giving high dose progesterone. So I did that with the lady. She got really, really, really sick during the first month. Then finally she started getting better. And after 3 months of like completing 6 months of Cytoxan, I biopsied her again, and still she had a lot of crescents. And I had to give her another 6 months. So right now I'm giving her 12 months of Cytoxan. Fortunately, we were able to catch it soon enough that her kidney function is the same as it was on day 1. She developed like AKI, acute kidney injury. Now she's back. And I'm dealing with a 20-year-old that she has the most aggressive form of Iga nephropathy, like the RPGN picture. So whenever you hear IgA, I want you guys to remember that it's most of the time it's pretty indolent, but it can be very aggressive. So we have like 4 or 5 diseases that are associated with RPGN, and one of them is IgA, the other one is lupus, the other one is ANCA, like the small vessel vasculitis associated with ANCA, and there is another syndrome that I'm sure you've heard on your textbooks. It's called Goodpasture syndrome. Have you heard about Goodpasture? So you guys know which is the antibody that you sent? You need to know this for your boards. No.
Antibody?
Yeah.
Anti-GBM.
Anti-GBM. So anti-GBM antibody. So we call it Goodpasture when it's actually involving the kidneys and the lungs. It's a pulmonary renal syndrome. When the disease only involves the kidney, we call it anti-GBM glomerulonephritis. And for your boards, if you end up getting a question on a patient with a GBM, with Goodpasture or GBM, the next step on the management is? Which one?
Oh, I was going to say, like, check their lungs if there's to see their.
No, let's say that we already established the diagnosis, lung and kidneys, and positive anti-GBM on the biopsy, positive anti-GBM on the blood. What is the next step in the management? Plasmapheresis. So always remember that, because they're going to give you like steroids, Cytoxan, whatever. So the answer is always plasma exchange. And you don't wait for the pathology to come back or the antibody. If you suspect it, you start doing plasmapheresis right away, because the morbidity and mortality is pretty high from this pathogenic antibody. Okay? So this is a picture I took from UpToDate. So I want you guys to think about like on your boards, they tell you joint pains, then you think about like explore polyarthralgia, you need to get a good history, good examination. If you see synovitis, then you need to think about, okay, these symptoms have been there for more than 6 weeks. If not, then you think about like a viral arthritis or an early systemic rheumatic disease. Sometimes these diseases can be very insidious. In other words, they can come and they can go and then come back again. So it's not like you're always going to start having symptoms and you're going to have a rheumatologic disease, but if they resolve, think about viral or maybe an early systemic rheumatologic disease, and you just follow them up. You don't need to treat them. So you need like the basic labs, you do blood counts, you need LFTs, and you consider like either doing a Hep B or hepatitis C serology or the parvovirus B19. And if you suspect acute disease, you order a parvovirus IgM, not IgG. Most of us, we've been exposed probably to parvovirus. It's pretty common. So make sure you order the IgM. But if you have symptoms more than 6 weeks, then you start thinking about systemic rheumatologic diseases. And then that way you actually do a CBC, ESR, rheumatoid factor, anti-CCP, ANA, creatinine, UA, and a joint aspiration. And here I would have added probably x-rays of the hands just to look for erosion, right? So if you don't see synovitis, you look for tender points. And have you guys heard about fibromyalgia? Have you guys seen patients with fibromyalgia? More or less. So fibromyalgia, it's funny because we, in every field in medicine, we have a disease that kind of tortures you. Today I was with one of my best friends, he's a pulmonologist, and he told me, I asked him like, what is it that you dislike from your practice? And he told me like, I get so bored and so annoyed from pulmonary nodules because I need to follow them over time. And probably not even 1 out of 100 are gonna be malignant, but I'm always terrified I'm gonna miss that. And so he's always like tortured about that. So for rheumatology, actually like rheumatology patients, they get a lot of business, for good or for bad, from from fibromyalgia patients. And fibromyalgia is a very complex disease, and we don't even know what causes it, but we know that there is some physiopath that has to do with sleep deprivation, with prior history of trauma, like I'm talking about psychological trauma. And a lot of these patients, they may have like depression or anxiety, and it's very difficult to treat because it requires that you are very involved with your patients, that you don't dismiss their complaints, that you're actually doing a multidisciplinary approach, because you as a doctor by yourself, you're not going to be able to successfully treat these patients, because you need to address all their needs. You need to make sure that these patients are sleeping enough hours, make sure that you're doing adequate pain management. And by adequate pain management, I mean refraining from prescribing narcotics, because this is a condition that is associated with chronic pain. And you guys have to remember that narcotics are only approved by the FDA for the management of acute pain or cancer-related pain. You never want to prescribe narcotics for things like migraine or for things like fibromyalgia. So, and it's very common that these patients, they end up getting treated when they come to under your care. They're already been to many physicians, and they're already addicted, you know, from making the wrong decisions to narcotics. So, and they need to be treated by physical therapy, and a lot of the times they need to be co-followed by mental health. So it's very complex. So the diagnosis, the clinical diagnosis, there's not such a thing like, okay, I'm giving you a test for fibromyalgia, and we assess for the tender points. I forget how many, I think there's 18 tender points. I think you look for them in right here in the posterior neck, in the upper back. I think you have another tender point here, right in the upper thighs, in the buttocks, in the lower back. And you need to assess for those points. I think you need to have 12 out of 18 to make the correct diagnosis. Just make sure that if you don't see synovitis and the patient have tender points, you're probably dealing with fibromyalgia or multiple sites of bursitis or tendinitis. So, but if you actually don't have any tender points, then you think about the differential is pretty broad. You think about either this is a viral arthralgia or osteoarthritis, or soft tissues abnormalities, neuropathic pain, metabolic bone disease, depression. You know, the list is pretty long. And